Hello, Assalamu alaikum, everyone. Dr. Azhar, can we please start the session because I have some
Yeah.
other
Actually, we
disclaimers
have
to.
uh, we have 1 minute.
Okay.
It is 1 minute to 8 p.m. So we have to wait for a few seconds more.
Okay.
Assalamu alaikum. I'm Dr. Azhar Rahman. On the behalf of PSA Karachi chapter, I welcome you all. So from today onwards, we are starting the pain management module. Um, our first speaker is in today's module is Dr. Asma Abdus Salam. Dr. Asma Abdus Salam. She is the program director, anesthesia and assistant professor and consultant anesthesiologist and pain physician at Dr. Ziauddin Hospital, Karachi. She is a CPSP supervisor in anesthesia as well. She is immediate past joint secretary, PSA, and she has a special interest in chronic pain and acute pain management. In her clinic, she do her clinic in Ziauddin Hospital, Clifton, Karachi. The second speaker that we have is Dr. Huma Saleem. She is a consultant anesthesiologist at Shaukat Khana Memorial Cancer Hospital and Research Center. So I welcome both the presenter in today's presentation. So before we start, I would request all the participants to please turn their mobile phone on mute mode. If you have any question, you can write it in the chat box. And at the end of the talk, a link will be shared. So all the participant has to fill the feedback form in order to get the certificate, e-certificate. So first of all, I would like to welcome Dr. Asma Abdus Salam. Please, Dr. Asma.
Thank you so very much, Dr. Azhar, for giving introduction of mine, and I'm really grateful to my team members, Dr. Vakas, and the rest of the members from PSA to arrange this session. And my special thanks today is for Dr. Huma Saleem. Basically, all of you have been knowing that I've been conducting all these lectures for a longer time, and I really wanted to be a part of one of the speakers, but just couldn't because we have been getting such a good response, even from the speakers, to present their talk, and we are really obliged to them. So finally, I got a chance to present my topic of interest, which is on pain management. I'm especially thankful to Dr. Huma Salim that she gave the time to me to present this topic. Basically, we both were supposed to give a topic on myofascial pain and fibromyalgia syndrome, but as we are courteous to Dr. Huma that she's presenting the topic now. So I'll just give a brief introduction on pain management and the basics of pain management, because as a pain physician, I think and I understand and I consider it very important that the basics should be taught, or basics, a review of basics should be done before starting this module. So please bear me for the next 10 minutes. I won't take long, Dr. Huma, and then the questions will be taken at the end of the session. So starting with this. I have nothing to disclose. And before we start our session, I would like to give a brief pain definition, which is given by ISP, and it was updated back in 2022, that the pain is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage or described in terms of such damage. That was the previous definition, which was given with a little bit modification in this similar one, but it's plus minus the same one. So as we all know that the pain pathway, there is a pain pathway. And before understanding the module, which we will be having in the next 3 or 4 months, it is very important to understand and to give a brief review of what exactly is pain pathway. So as you all must be knowing that whenever an injury occurs, there is a physiology which is connected from the spinal cord to the brain, and that's how the pain is perceived and then transmitted. So I'll be talking more on that. So it all starts with the nociception. Nociception, it refers to the detection of the noxious stimulus, as you can see in this slide, which is by the nociceptors, which is followed by transduction and transmission of the sensory nervous system from the periphery into the brain, as you can see here. Now, the nociceptors, they are the receptors for the signals or the molecules or the stimuli, and they are found in skin, muscle, joints, bone, and organs, or any kind of response. They respond to a number of different stimuli. So they are our pain sensors. And there are different type of nociceptors which exist in our body. They are basically encapsulated cutaneous ones, which are activated through different stimuli, and they exist as free nerve endings, as you can all see. So there are three types of nociceptors, which are mechanical nociceptors, thermal and mechanical thermal nociceptors, or the polymodal nociceptors. We have all been knowing this. So mechanical nociceptors, they detect sharp pricking pain. However, the thermal or the mechanical pain, they detect the sensation which elicits pain, which is slow, burning, or cold or sharp in nature. However, the polymodal nociceptors, they detect the mechanical, thermal, and the chemical stimuli. So basically, all of these nociceptors are different types which are stimulated according to the stimuli or the stimulus or the injury which occurs at that time. And this is just a quick picture or the quick reference of whatever we have just known. So when there is a potential or the actual tissue damage, the substances such as prostaglandin, they are produced, as you can see here. And these prostaglandins or the inflammatory mediators, they either directly stimulates the nociceptors, which are the pain receptors in the tissues, or they sensitizes them to a readily acceptable noxious stimuli. And when the tissue damage occurs, there are other factors which also gets released, as you can see in the picture in the bigger circle, that there is bradykinin and there is potassium, and then from the mast cell, the histamine and substance P, they also get released, and from the blood vessels as well. So all of these noxious stimuli, they travel directly and stimulates the nociceptors, and from there the signals, they transduce, or the signal is produced and it goes into the dorsal root ganglion, as you can see here. So this is a basic picture or the basic depiction of the pain and of whatever pain you might be seeing in your patients, either it's acute pain or the chronic pain. The mechanism lies here, and this is just a brief summary of whatever you have already been knowing, or if you have forgotten, then that's for the residence part. This is for you, that whenever the noxious stimuli, as you can see on the left side of this picture, that either it is from the skin, joint, or any other stimulus, the noxious stimulus, it incites the signals, and then the signals, they go first into the first order neuron, which is the dorsal ganglion. And the nerve fibers which are associated are the first order neurons, are either A delta fibers or the C fibers. And for the summary, for the residence part, A delta fibers, they transmits the myelinated, they are the myelinated fibers, and they transmits the localized sharp pain. However, the C fibers, they are the unmyelinated ones, and they transmits the slowly, poorly localized pain. So once the pain goes into the dorsal, perceived in the dorsal dorsal root ganglion, as you can see here. I'm trying to scroll it, but unfortunately the scroller is not there. So from there onwards, you can see that the nerve signal, the signals, they go into the dorsal horn, and from there they decassate, and they come on the opposite side of the spinal cord, and then they decassate upwards in the form of the second order neuron. And once they go into the second order neuron, then there is the rex lamina of the spinal cord, where the cranial nerves, they also lie. And from there, the cell bodies of these neurons, they transmit, and then they spread the pain upwards into the thalamus. These are the rex lamina, and predominated by A delta fibers. And then when the pain is perceived in the third order ganglion, that's the thalamus. From there, the somatosensory cortex is also affected, and the pain is perceived. So all of this mechanism is actually divided into three neurons, which are first order neuron, second order neuron, and third order neuron, which one has to, and especially the juniors have to remember. Then there are the mechanism, which is the transmission, transduction, transmission, perception, and modulation. These are the four basic mechanisms of the pain pathway. And then there is the ascending and the descending pathways. Ascending pathways, as you have just seen, and then there are the descending pathways. So when we talk about transduction, it's just the transmission of the signal from the conversion of the tissue injury from the peripheral nerves or the terminals of the peripheral efferent neurons to from the one form of energy, and it is converted into the electrical energy, which is the another form. That's called transduction. Then transmission, as the word says, it's the transmission of the nerve energy from one part to the other part, from the periphery into the dorsal root ganglion. In the second order neuron, they get modulation, and then there is the ascending pathway, and then when they go up in the brain, they again perceive, and that's as the name suggests. And then the descending pain pathway, or the descending in the descending part of the pain pathway, there are two fibers which are involved. Either they are the inhibitory fibers or the excitatory fibers, and that's how the action takes place. So this is just the basic anatomy and the basic methodology of pain. And there are several updates and several topics which have been further discussed on the basics of pain, and in recent articles as well, even in 2022, 2024. Now the recent literature is being done, and the recent studies are being done on the molecular level, which is also one of my topic of interest. And there are different adenosine receptors which are emerging as the non-opioid targets for the pain medications, because it's otherwise known that the adenosine receptors, they are otherwise low, present in the low concentration, but can increase in response to the stressful stimulation and situations as per the cellular damage. And the other studies have also shown that there are different type of mechanical and the molecular level involved, especially in the dorsal root ganglion. So that's one of the subject and one of the topic of the latest research in these eras. So there is basically a difference between the somatic nerve and the visceral nerve pain, and visceral pain or the somatic pain. And the major difference is the presence of the sympathetic chain, that from the visceral pain, as you can see, the viscera, they transmit their pain signals into the sympathetic chain, and then later onwards it goes to the dorsal root ganglion. However, as far as the somatic input is concerned, the pain which is perceived somatically, it first directly goes into the first order neuron, which is the dorsal root ganglion. So that's the basic of the pain, which is the basic physiology and anatomy. And then, as you all know, that there are different classifications on which the pain is being perceived, and the pain is classified according to the pain physiology, whether it's be nociceptive, neuropathic, inflammatory. They can be according to the intensity, which is mild, moderate, or severe, and according to the time course, as you have already been knowing, either acute or chronic, or according to the tissue types, which we will be discussing in the module in the further classes in the lectures on either the skin or the muscle ones, which Dr. Huma is about to talk, or the visceral joint, tendon pain, bone pain, or syndromic pain like cancer pain, fibromyalgia, migraine, or the temporal characteristics. So these are all the classification of pain. And definitely we all do classify time according to the time zone, which is either the acute pain, chronic pain, or acute on chronic pain. And we all know the definitions of acute or chronic pain. But according to the ICD-11, which is the international classification of the diseases, which is adopted by the World Health Organization. And they have described the chronic pain both as the primary disease and also as a symptom of the other illnesses. And mainly they have divided the chronic pain into 6 main categories, as all of you can see in the slide, which includes the chronic cancer-related pain, the post-surgical pain, neuropathic pain, headache, visceral, or the musculoskeletal pain. And definitely we will be discussing these later on. But the neuropathic pain, again, have been divided further into the peripheral or the neuropathic pain. So that's the latest, and that's the new changes which WHO have done according to the ICD. So whenever you see a patient, you all know that you have to first make a diagnosis, and then you have to assess the patient. So there are definitely many scales and many validations on the pain intensity. But whenever you assess a patient, always use a validated pain score, which is mainly a visual analog score, which is VAS, or the numerical rating score, because that's valid, that's reliable, practical, and it can correlate with the other skills. And definitely many studies have been done on these pain scores. So always have a good assessment of the pain. And these are different pain scores. I'm not going in detail in all of these because I had to give just a very brief overview of what the pain is, what exactly is the pain, etiology, what you will be seeing in the and hearing from the other speakers would be an elaborate one. And this was just a quick review. So I'm grateful to PSA that they gave me an opportunity to present today for 10 minutes. And I would request Dr. Huma Saleem to take over and give us an overview on the latest updates and guidelines on on the myofascial pain and the fibromyalgia syndrome. So thank you, everyone. And if you again have any query, any question related to the basics and the latest articles or the latest guidelines on, not the guidelines, but the latest research, if you want to know the latest research on the basics or the molecular level of pain receptors or other, please let me know. I'll be happy to share with you the articles. Thank you so much, everyone.
Thank you, Dr. Asma. We will take the question at the end of the session. So welcome, Dr. Huma. Please, you can start your topic.
Assalamu alaikum, everyone. I'm Dr. Huma, and I'm immensely thankful to Dr. Asma for the opportunity to present alongside her today. The insights shared by Dr. Asma in her lecture have actually enriched our understanding from the basics, and it will undoubtedly contribute to the ongoing education in our field, which will go on further increasing and enriching as we move down the modules through this series. I would like to thank PSA Karachi for organizing these online sessions, because it is actually the dedication to sharing the knowledge. Sharing knowledge is actually inspiring as well as appreciated, because it's a continuous journey of learning together. And I'm sure that everyone here today has already benefited immensely from the contributions of Dr. Asma and her team at PSA Karachi. So thank you for giving me this opportunity to present here today about the myofascial pains and fibromyalgia. So in my presentation, Assalamu alaikum. So through my presentation, I have no conflict of interest to disclose. And today we are going to discuss about myofascial pains and fibromyalgia. So in order to, we need to know that it is the most common reason for which the patients actually seek medical attention. And when chronic pain happens, it actually results from a multitude of processes. The multitude of processes can be either biological or can be psychological, or even social factors may be involved. So it actually requires a multifactorial approach, as Dr. Asma has already mentioned in detail about the pathways of pain transduction and modulation. So we are going to just go ahead with the multidisciplinary approach that we need to adopt. So what fibromyalgia is actually a chronic and widespread musculoskeletal pain disorder. It is a pain disorder which is characterized by a multitude of other symptomatology as well. It can be with fatigue. It can present with sleep conditions as well, such as there can be irritable bowel syndrome, there can be a chronic fatigue syndrome, or even patients with chronic headaches may present with fibromyalgia. It is present in as much as about 2 to 8% of the population, but this population is actually having widespread pain. This widespread pain causes memory problems, sleep disturbances, and fatigue, thus making it difficult to perform everyday daily tasks. And patients generally respond best when multidisciplinary approach is applied. And we use individualized, tailored programs. Those tailored programs should include both the clinicians as well as the non-clinical healthcare providers. They should include the primary care physicians, they should include the physical therapists, and also the mental health specialists. So regarding epidemiology, we see that in USA, the prevalence is about 2 to 3%. And this prevalence increases with ages. And as the age is also a determining factor, gender also comes into play. It is 6 times more common in women, and that too between the age quarters of 20 to 55 years. So the diagnosis may be under-recognized. How under-recognized? Because the prevalence estimates are greatly variable because of non-specific diagnostic criteria. The prevalence of fibromyalgia is much higher using the surveys with standardized criteria than it is estimated upon the general clinical practice. Because sometimes when we apply the standardized criteria which are selected by the different societies, we can actually see that the prevalence of fibromyalgia is much more, that is 6.4 as compared to the 1.1%, which we find if we only check onto the general practitioners' medical records. So how can we actually consider fibromyalgia? It is a complex thing to describe, but it is a disorder of pain regulation. So this is classified under the term of central sensitization. There is a central sensitization which causes amplification of the neural signaling. Within the central nervous system, this leads to pain hypersensitivity response. It can be accompanied by peripheral pain mechanisms as well, but the central mechanism plays the major role. In the peripheral mechanisms, neuropathic pains, such as small fiber neuropathy, or nociceptive pains, such as from an inflamed joint, may also be there, or may be accompanying fibromyalgia, or may be there and misnomered as fibromyalgia. So we will discuss it in the differential diagnosis as we go along the lecture. So there is some genetic predisposition to this problem as well. So central hypersensitization occurs in the first degree relatives of patients with fibromyalgia. And they have 8.5 times more chance of having fibromyalgia than the relatives of the patients who have genetic predisposition in case we are dealing with central hypersensitization. So Datta and his colleagues, they did a study on fibromyalgia patients, and they included 26,000 or more individuals in undergoing elective surgical procedures. And they found that the fibromyalgia phenotype has a stronger genetic component in younger individuals as compared to the older ones. So it is heritable, and its heritability is classified at 14% of the total population. So the serotonin and opioid pathways may also act. The pain-related genes that have been potentially associated with fibromyalgia are those for COMT or mu receptor agonists, or there may be voltage-gated sodium channel involvement along with the GTP cyclohydrolase 1s and the GABAergic pathways. So there is ability, or there is some degree of potential of some antidepressant drugs to help us in the treatment of this fibromyalgia and help us to improve the symptomatology. So what is nervous system hyperirritability in fibromyalgia? It is actually associated with both the central nervous system, the peripheral nervous system, and the autonomic nervous system also comes into play. So what happens when the central nervous system is hyperirritable? It causes sleep and mood changes. It causes cognitive disturbance and stress, genetics, and environmental factors. All of these can contribute to this central nervous system hyperirritability. So here we can see that there is some cognitive element involved, but there are social elements and the environmental factors affecting the symptomatology, which is evident in these patients. Then when we look at the pain from a small neuropathy or a nociceptive pain such as that,
Dr. Huma, your voice is not apparent. We can't hear you, Dr. Huma. I think she's having some internet issues. Our team will be sorting it out soon. Dr. Waqas, can you please contact her and let her know that I think she has gone offline.
So there is no voice. I think she's lost her connection. Dr. Huma, are you there? Hello.
Assalamualaikum, sir.
Waqas, could you please call Dr. Huma and ask what exactly she's facing now?
She's reconnecting it. She's asking for 2 minutes.
So it's okay. I think she's joining us. In the meanwhile, if you have any questions, you can ask me so that we can continue the rhythm of the lecture. And if there is any query related to the mechanism or any, especially from the resident sites, because that's an essential point to understand, and that's the first thing to be learning when someone comes into pain management or doing the rotation. So if you have any question in understanding, just let me know. I'll try to explain it. Okay, we have Dr. Huma back. Then you can ask the questions later.
so sorry for the technical glitch. I hope I'm there in the meeting now, and can I be heard?
Yes,
Yeah,
Dr. Huma, you
If
can
someone
proceed.
can confirm that, please. Okay, thank you. So we were on the part where we were trying to discuss about the diagnosis of fibromyalgia. So as we know that it is a disease dilemma that when it is difficult to diagnose, and over many decades, much effort has been done to develop a diagnostic criteria to help in that. So there are multiple systems involved, multiple comorbidities associated with these patients having fibromyalgia, and it is thus difficult to diagnose and is still underdiagnosed and undertreated. So it may take more than 2 years for patients seeing a physician, and at least 3.7 different physicians at a time for having a diagnosis of fibromyalgia done for them, and some constitutive measures done to help them in their treatment. So many healthcare providers, especially the primary care The reporting criteria is not clear, and they don't have confidence in using the existing criteria, thus making training in this field a mandatory requirement for accurate diagnosis of the syndrome itself. So in 2013, action partnership was done with FDA and American Pain Association, and they developed a taxonomy or apt taxonomy for an attempt to help in the diagnostic system development for fibromyalgia. So in 2019, the working group suggested a diagnostic criteria of having a multi-site pain with 6 or more pain sites, or a total of 9 sites. A moderate to severe pain, which causes severe problems with sleep and fatigue, or both of these criteria, or both, or any one of them must be present for at least 3 months before we make a diagnosis for fibromyalgia in this regard. So regarding the diagnostic criteria, what we can find in our history is that there is a multi-site pain as said in the apt criteria, and this pain needs to be present for at least 3 months with sleep and fatigue disturbances. A cognitive disturbance, headache, or bowel irritability may also be there in the conundrum. Then during the physical examination, we might find widespread tenderness. It is a multi-site tenderness. It is not focal or localized. There is absence of joint swelling or inflammation, and laboratory testing may reveal normal acute phase reactants like the ESR may be normal, the CRP may be normal, the patient may be having a normal CBC, and muscle enzymes and thyroid testings, if indicated or warranted, may also turn out to be normal. So the hints which we use for early and cost-effective diagnosis of fibromyalgia is that if we find a chronic widespread musculoskeletal pain, that musculoskeletal pain is multi-site and is there for more than 3 months. There is absence of any other systemic conditions which might account for the pain or excessive tenderness in the soft tissues. The patients usually characteristically give a statement like, I hurt all over. I feel like I have a flu at all times. I have fatigue. I cannot concentrate on work. I have sleep and mood disturbances. My bowels remain irritable. And then in addition to that, there is no other structural or systemic disease to corroborate these findings. So once the diagnosis is done, it is important to make a good differential. So the things which might confuse or make the diagnosis of fibromyalgia a bit more tricky or difficult are rheumatoid arthritis, or lupus. If this is there, then there is involvement of multi-joints, and there is no joint inflammation in fibromyalgia. In polymatic, detecting high calcium levels in the serum chemistries, and in neuropathic pains, there may be clinic of having a neuropathy. So if these are not there and we actually fulfill the apt criteria, then we are on to our diagnosis of fibromyalgia. So what clinical manifestations can we find in these patients? Generalized pain, cardinal manifestation. It is a multi-site pain. It cannot be localized. There are no tender spots, but there are multiple site tenderness all over the body. In a 2018 report, which was done by an expert working group, they suggested that multi-site pain more than CWP to define the fibromyalgic pain. And this pain is more at least at 6 sites, and counting up to 9 sites, may include different parts of the body like the head, the arm, the chest, the abdomen. Both the legs might be involved, back or spine, lower back, spine. But all those things, you can see that these are actually involving different areas of the body, not to a generalized, going to a generalized setting rather than a localized muscle setting. Sometimes the pain can be initially, for some time, be localized one, like in the neck or shoulders. But sometimes patients actually describe it predominantly starting from one area, and then it starts going all over the body. Fatigue and sleep disturbances are also very common, and these actually are heightened by prolonged periods of inactivity. Patients are usually stiff in the morning and feel unrefreshed even after having slept for 8 to 10 hours. So if we can see and relate this activity to the age quarter, so if it is between 22 to 55 years of age and you do not feel fresh or you feel fatigued even after a sleep of 8 to 10 hours, then it leads to loss of productivity. And thus, this actually affects the life and the societal balance. The morning stiffness may be difficult to differentiate from rheumatic fever or rheumatoid arthritis, but in patients of fibromyalgia, they sleep lightly, waking frequently during early morning, and difficulty getting back to sleep is also cardinal. So all this sleep disturbance, all this mood disturbance leads to cognitive and psychiatric symptoms as well in these patients. And cognitive disturbance in fibromyalgia patients is especially termed as fibrofog. Fibrofog is actually reported by lots of patients who present with fibromyalgia. They have described it as problems with attention and difficulty in doing tasks that require rapid thought movements or rapid thought changes. So when Wu and Huang, with their colleagues, performed a meta-analysis, they did it on 23 case control studies and found significant cognitive impairment in patients with fibromyalgia when they compared them with their healthy counterparts, and explained in parts by the level of their pain relating to their level of depression. So how do we overall do the overview of the clinical approach to these patients? First of all, we diagnose them, then we diagnose them timely, then we diagnose them in a cost-effective manner. And once we have diagnosed them, now we need to give them a full overview of how we are going to manage their disease. So first of all, we need to individualize the treatment approach. It has to be tailored to the specific patient's clinical manifestations, the comorbid conditions which are there in that patient, and the decision has to be a shared decision making. So we need to involve the patients as well as the care providers in the primary care level, and then the specialized pain physicians to help in the treatment of fibromyalgia and in these individuals, thus alleviating their symptoms. So if the prominent symptoms, including pain, fatigue, and sleep disturbances are there, then we need to ask the patient about how they wish to optimize their treatment. If they have any past experience with treatment, do they have any contraindications to the medicines those were offered to them? If they have any comorbid conditions, any concurrent disease, any polypharmacopoeia which is happening to them, if they have a level of fitness which can be any easier for them to do aerobics, to do stretching exercises, or would there be any barrier to exercise? And especially important is to take into account the psychosocial elements. The social determinants of health that are important are also there to modify the symptoms. And therefore, if the symptoms are modified by it, we need to engage the patient to help with a particular treatment in fibromyalgic patients. So if there is a major mental health disorder like depression, anxiety, or PTSD, post-traumatic stress disorder, we need to address them individually. Then primary sleep disorders like obstructive sleep apnea or restless leg syndromes may also be there in these patients and needs to be addressed along with the treatment of fibromyalgia. Patients with polypharmacy require a careful medication reconciliation. Like we need to check if the side effects of one drug may further accentuate some pre-existing disease, or there may be a synergistic or antagonistic effect of certain medications with each other. So identifying the medications that might worsen the fibromyalgia symptoms is also very important, because the symptoms might worsen by using antihistamines or anticholinergic drugs. And in some patients, beta blockers, opioids, and benzodiazepines may also be difficult to use. So our goal of treatment, the goal of treatment is to reduce the major symptoms, reduce the multi-site pain, reduce the fatigue, and the mood and sleep disturbances. Then the next aim is to increase the patient's self-efficiency. The self-efficacy is with empowerment. Empowerment happens through education. And this education is done with patient-centered approach. There should be patient-centered communication and providing the implementation strategies to help them to do the non-pharmacological interventions for the pain control in fibromyalgic individuals. These pharmacological and non-pharmacological therapies need to be tailored to each patient's individual symptoms. And then we need to recognize and treat the comorbidities as well. So we need to actively participate as a team and not as individuals in the treatment of fibromyalgia, with patient as the main stakeholder, along with all the other specialties working around the patient to help him alleviate his symptomatology. So what can be the choice of initial therapy in patients with fibromyalgia? So this is a suggestion of the American Society of Pain Physicians, and they suggest to implement the core non-pharmacological measures, which include the patient inclusion with the explanation of the complete cause of the symptoms and explain the centralized nature of the pain to them. Discuss with them the sleep modalities and how can they improve their sleep. Then increase their physical activity and exercise according to their requirement of the body. Maybe low impact aerobic exercises may help us, or sometimes resistance exercises may be more useful. Then we need to give in the psychological or cognitive behavioral therapies or mindfulness stress-based reduction therapies. And if there is any reason to use a trial of non-pharmacological measures alone, yes, there can be mild symptoms. There can be no coexisting sleep or mood disturbances. But what if they are there? What if there is sleep or mood disturbance? Then yes, we need to continue with the non-pharmacological measures, but then we need to initiate the pharmacological measures as well. So we need to choose one agent which is based on the most important symptom which the patient defines. Most commonly, patients define pain or multi-site pain as their main symptom, bringing them to the clinician's care. So we need to give a trial of amitriptyline, or we can use any other related tricycle. And if there is prominent sleep disturbance, then we can use alpha-2 ligands, like we can give pregabalins or gabapentin. So if we discuss them in a bit of more detail, so if we use tricyclics to control the diffuse widespread pain without major comorbid mood or sleep disturbance, then amitriptyline and cyclobenzaprines are the treatments of choice. And they are started first at low dose to 5 to 10 milligrams and taken 1 to 3 hourly, then increased gradually until the response is achieved. Severe fatigue or depression, SNRIs like duloxetine or milnacipran can be used. And if there is prominent sleep disturbance, then pregabalins and gabalin, starting at a low dose of 25 to 50 milligrams at bedtime and increasing slow incrementally by 20 to 50 milligrams every 2 to 4 weeks till the response is achieved. So how do we evaluate the response? What is the response to the initial therapy? There are certain patients who would respond to the initial therapy, and there will be certain others who do not respond. So the patients who do respond to initial therapy, the patients are kept on that medication indefinite periods of time till the patient tolerates the medication. However, sometimes it does happen that if the symptoms get controlled, the patient tend to discontinue the medication. And this happens because of the cognitive element associated with the disease, because once the patient sees an improvement and finds that now the use of medication is questionable and the clinical significance no longer exists. So we need to convince them, and that is why we need to include them in the initial therapy design so that they continue to take their medication even once the symptomatology improves, unless they find that they cannot take that medication because of certain side effects. And there might be patients who do not respond to therapy. So for those patients who do not respond to initial therapy, they might have symptoms despite adequate trial of non-pharmacological as well as pharmacological drugs. So the providers would need to assess their changes in pain. If the pain has changed from before and has lessened now, or there is progress in meeting the functional goals of the patient. So if the patient reports that there is improved pain, but they are not able to perform their functional goals, then the medication is actually beneficial. And if we need to check the goals which the patient has in mind are actually realistic or relevant at that time. But if the patients are progressing in meeting their functional goals, but the level of pain is the same, but the patient might think that the level of pain may be the same, but as the functional goals are being met, so it actually leads to the medication therapy being a bit less underappreciated as compared to the actual benefits it is providing to the patient. So in this, we actually learned that the providers need to carefully sit down and talk with the patient and discuss their course of improvement over small periods of time as they meet up again and again, and thus realizing when the treatment is effective and how to up or down regulate the treatment. So if the symptoms are refractory, then clinical reassessment and assessment and reassessment is the main paradigm. The providers should ask the patients about their experiences with different pain modalities which are given to them, like their perceived treatment efficacy, what they wish the drug to do for them. Do they want their sleep pattern to improve more, or they want the fatigue to be gone, or they are only concerned with the pain, what needs to be improved more. So that increases the acceptability of the treatment, and thus we make the treatment more accessible and acceptable to the patient. At the same time, we need to be mindful of the adverse effects and need to check if there are any barriers to implementation or maintenance, like the maintenance of non-pharmacological therapies like exercise, or there are certain other behavioral therapies, if they are available to the patient, if there are any financial restraints, if those financial restraints can be helped with. All these things are important. So thus, this treatment plan reaffirms the multimodal approach, reaffirms the active patient participation, and reaffirms the need to work together to achieve effective fibromyalgia treatment. So what can be the response to medication? Whether they experience any benefit from medication, whether it is completely ineffective. So the two of the most common reasons for the medications to discontinue is actually the adverse effect of the drugs in 40% of the population, and only 23% of patients report a lack of efficacy of the drugs. And sometimes they need to find the rate limiting adverse effects, if they can be there in therapeutic doses or in higher doses. So we need to see where we find the optimal drug usage. If the drug dose or drug usage is not optimized, then this results in discontinuation of treatment in 73% of the patients coming to us for fibromyalgia and related disorders. So what is the experience with non-pharmacological interventions? Like if physical activity and exercise, are they achievable? Are they able to improve their generalized health and activity with it? If there is a cognitive or psychological therapy there, if there are any barriers to achieve that therapy, if there are good sleep pattern, is the sleep routine changed, is it disturbed because of any stress disorder, which might have led the pharmacological therapy to lose its efficacy now. So all these interventions go hand in hand and side by side. With the peripheral pain evaluation, we need to be mindful of the peripheral neuropathies, the localized inflammations like tendinitis and bursitis, any localized inflammation of the joints like osteoarthritis or inflammatory arthritis, because patients with nociceptive pain might require other agents depending upon their cause of pain, which is not specifically related to fibromyalgia itself. For example, if the patient is may require physical therapy, may require gait modification, especially if they have some gait problems because of being flat-footed and having greater trochanteric pain syndrome as a result. So thus, switching to alternative pharmacological therapy, we need to first carefully evaluate whether the therapy is given to the patient and whether it is being received in the same manner as it was prescribed. So once it is established that the pharmacological therapies are not working, then we might need to shift to other drugs, like we might need to switch to SNRIs, or if the patient's sleep disturbances still persist, then we need to add on the alpha-2 ligands, like gabapentins and pregabalins. And the medications need to be tapered and need to be tailored. If the medication dose need to be up-titrated, then it needs to be up-titrated in slow incremental doses. And same wise, if the medication should be tapered down, then it has to be tapered down over time to avoid any withdrawal-like symptoms. So these withdrawal-like symptoms are most common with gabapentins and pregabalins. Therefore, we must be very mindful while we are tapering these drugs to avoid the withdrawal syndromes. Along with the non-pharmacological therapies, other therapies like improved nutritional and diet improved injection therapies like acupuncture, trigger or tender point injections might also work. Neuromodulation has some role in maintaining the therapy which is being provided to the fibromyalgic patients with tense transcranial magnetic stimulation and the underlying mechanism of neuromodulation responsible for reducing the central hyperexcitability experienced by these individuals. The important point is we need to know when we need to refer to specialized pain physicians. We need to refer the patient when there is difficulty in increasing the physical activity, despite giving all the non-pharmacological methods like physical therapy or cognitive behavioral therapy. There might be uncertainty in diagnosis. We might feel that this is not fibromyalgia or some other peripheral pain phenomena acting up, or the patients might not be responding to their initial therapy, or sleep and mood disturbances are not controlled. The prognosis is sometimes it's better to explain the course of the disease as well as the prognosis to the patients so that they are better involved. Otherwise, if we do not disclose this prognosis to the patients, sometimes they may feel that there is no treatment available for their symptoms and they might feel helpless in this regard. So if the symptoms are persistent, they can impact the psychosocial dynamics and the demographic dynamics of the patients as well. So in order to help them to prevent any disability or a tendency of self-harm, we need to have an inclusive effect of treatment involving the patient in the entire course of disease management. A little bit about the myofascial pains. So in contrast to the fibromyalgia, myofascial pains are actually regional pain disorders. They are characterized by special trigger points, which trigger points are present through the muscle or fascia. So they are actually hyper-irritable spots, not a generalized tenderness, but hyper-irritable spots, which are actually present within the taut band of skeletal muscles. This skeletal muscle pain may be because of the muscle fascia, or it may be painful because of compression. But this actually can give rise to characteristic referred pains, tenderness, and other autonomic phenomena may also be associated with it. Epidemiologically, it is relatively more common source in the general population. And there is lack of accepted diagnostic criteria, therefore it is underdiagnosed, and thus epidemiological studies cannot be thus readily estimating the disease load of myofascial pains. One study was done and it actually perceived it to be the primary presenting complaint in a major chunk of 70% of the population. The clinical significance of the features is slightly different from what we find in fibromyalgia. So in contrast to fibromyalgia, there is a burning or a stinging sensation. It is a peripheral phenomenon rather than central. And then once we find it is just one anatomic site, it is localized. And sometimes the patient can actually complain about restricted active movement in the area which is affected by the myofascial pain. There is characteristic presence of myofascial pain trigger points. So looking at the figure, we can see that the most common site of myofascial pains is iliocostalis muscle or the erector spinae, the multifidus, the piriformis or the gluteus maximus muscle. So you can see that it is actually the spots, the tender zones which are indurated to feel and palpate, and they reproduce the pain in the target zone even when they are stimulated. The trigger points may happen because of acute trauma, or there can be micro trauma repeating every day because of some occupational habit or because of some daily living habit. Or there may be a chronic strain on certain muscles because of sedentary work style, because of continuous desktop jobs. So most clinicians are skeptical about the existence of trigger points, but reports have evaluated them to be still persistent and pertinent to patient management. So what other associated symptoms we can find? We can find tension headaches. We can find lower back pain, cervical strain disorders, or repetitive strain disorders, which are very common in occupational overuse syndrome. There may be accumulative trauma, like small micro injuries happening over a period of time and then getting accumulated, giving rise to myofascial pains, a work-related myofascial disorder, or there may be a TMJ syndrome. So in head and neck, like the pain may be associated with unexplained dizziness. There may be a neurocognitive or neurovestibular disturbance along with the pain, but this is basically localized tender spots distributed in a band of skeletal muscle or muscle fascia. So the initial approach is to exclude systemic disease. First of all, we need to see what is causing this pain. Then we need to eliminate the aggravating factors. Then again, the patient finds a pivot role, and the patient is the central, and he needs to be explained his disease course. Then after inclusion of the patient in the entire strategy, we need to have self-help strategies there for the patient to provide adequate pain relief and thus help with the prognosis. Systemic diseases, a wide array, but we need to just importantly see if there are any endocrine disorders like hypothyroidism. There may be an inflamed joint as in arthritis or arthropathy. There may be a concurrent celiac disease. There may be a concurrent chronic infection. All these need to be carefully evaluated and excluded before making a diagnosis of myofascial pain syndrome. Then aggravating factors like any occupational hazard, any improper sitting or work ergonomics which are insufficient and may lead to taunting of the skeletal muscle area need to be avoided. Soft tissue strain from repetitive job tasks or a new hobby. A patient just developed a likeness for playing badminton or football. They can be recognized and actually modified. So a biomechanical strain from any structural disorder, like there may be a flat foot patient, or there may be a head forward posture for a patient. These can be carefully modulated and changed with appropriate physical measures. So psychosocial factors like mood disturbances, chronic insomnia may also contribute to aggravating and therefore need to be eliminated for treatment of myofascial pains. Patient needs to be given a reassurance that this is a skeletal tissue disorder and is not rather a more serious disease like rheumatoid arthritis or a SLE. So validation given to the patient that their problem is real actually helps more and helps to relieve anxiety. And this makes patient an active participant in the treatment strategies. It gives them a sense of control. It helps them to use their home therapeutic exercises and to do ergonomic modifications like standing desktops at their workplace. And some patients may actually benefit by including aerobics or strength training exercises in their daily routine. But this cannot be done unless the patient is given control over his disease. And then the prognosis need to be explained. The clinical course completely explained to the patient in the initial visit if it is possible. The patient should also understand that this course is dependent on his performance on the self-help designed program. And the response to the program may actually impact his diagnosis and his treatment course. We need to provide adequate pain relief. This can be done through heat and cold compresses. Topical and oral analgesics may also help. Localized injections into trigger spots like lidocaine may also be used by certain practitioners. Acupuncture for neuromodulation and extracorporeal shockwave therapy has also been successfully employed in certain case analysis. So the most important thing which we need to differentiate between fibromyalgia and myofascial pains is that pain localization is a very important symptom, which is widespread in fibromyalgia, but is localized in myofascial pains. Trigger points are present in fibromyalgia, are not present, I'm sorry, they are not present in fibromyalgia and they are present in myofascial pains, and associated symptoms are more common in fibromyalgia. Myofascial pains are usually isolated, are because of certain micro trauma or continuous injury happening to the skeletal muscle or to the fascia, and therefore can be very easily treated and avoided. Thank you so much for your time, and I would like to thank Dr. Asma again for co-presenting with me in this talk. And I'm very thankful to PSA Karachi for these online series and helping us enriching knowledge in all the modules to come. And I wish them all the very best for their future endeavors as well. Thank you so much. All queries are welcome. If you have any queries, please. Thank you.
Thank you so much, Dr. Huma. That was really nice hearing you, and thank you all the participants. The feedback form will be shared very shortly. So if you have any questions, I'm just reading out the chat box. So Dr. Haq Dad Durrani have asked about the magnesium He was commenting earlier as well on the role of magnesium in fibromyalgia and also on the sleep disturbances associated with fibromyalgia. So, Dr. Haddad, can you please unmute your microphone so that you can ask the question directly to Dr. Huma?
Am I audible?
Yes, you are audible. Thank you.
Ji. Magnesium suppresses all excitable tissue, nerves, muscles, pain. So pain, more probably, magnesium is usually intracellular than extracellular, and its deficiency is less likely to be diagnosed by extracellular potassium magnesium. तो एक तो इसमें एक बात यही है कि अगर आप
Sorry,
magnesium
Dr.
का role
Haddad, actually we also have other participants from other countries,
जी
so if you can please keep the
ठीक
meeting
ठीक
English, I would request you to
जी जी
continue.
My purpose is if is there any study role of magnesium in fibromyalgia or not?
Thank you, Dr. Haddad, for your query. As far as I have seen, there is not research evidence on the use of magnesium for the treatment of fibromyalgia. But yes, if there is a comorbid condition, like you mentioned in your chat box, that there is some reason where the calcium and the magnesium ions interplay. So yes, then we need to resort to specific measures, and then magnesium may be a useful drug adjunct to the treatment of fibromyalgic pain. So it depends upon mainly what the symptom is, what symptom is actually bringing the patient to the clinician, and we need to tailor our treatment according to that.
Thank you.
Thank you so much.
And we have Dr. Muhammad Ahmad Ashraf is asking about the role of ketamine infusion, along with Debashi Ganguly, who's also commenting on lignocaine infusion, about the dose and the regimen used.
So yeah, both the lignocaine as well as ketamine, as they serve to change the central hypersensitization to the brain. So the peripheral input is stopped in case of lignocaine, and central hypersensitization can be avoided with the use of ketamine. So they do have reported benefits, but till date, there is no meta-analysis done, and more data is yet to be concurred for their efficacy in treatment of fibromyalgic patients.
Thank you. Prolotherapy. Dr. Shahid Rasool is asking about the role of prolotherapy and how to inject it.
Sorry, I couldn't get the word.
Prolotherapy. Dr. Shahid, can you please unmute your mic and ask the question directly to Dr. Huma, please?
Thank you. You want to ask the role of any prolotherapy or what to inject in a trigger point injections?
So as for trigger point inductions, different agents have been used, like lignocaine has been used. Sometimes there's some way back, Botox was also employed for this purpose. But there are scattered and sporadic evidence for that. The detailed evidence for use of any one particular agent for our trigger point injection is not there. But it actually depends upon how one can control over the symptoms. So sometimes there is a slight stimulation with pressure required, and acupuncture works best for trigger points. But sometimes we need to inject lidocaine or even Botox for certain cases. So yeah, it may be there, but it depends upon the patient's response to the different infusions or the drug agents we employ.
I think, Dr. Uma, there is also a role of injection bupivacaine in the trigger points, because lignocaine injections as trigger points, they have a very small duration of action as well as the time. However, the bupivacaine, it acts a bit longer, and the patient's trigger points, they really get resolved with those. So in patients who are having myofascial pains along with fibromyalgia, and one of the cause of fibromyalgia syndrome, in those patients, I think literature has also shown evidence of bupivacaine use in trigger point.
Completely agreed, Dr. Asma, because yeah, as one can see the efficacy done once when we do a short-term injection, then yes, if there is a efficacy, we can always use a longer-acting agent.
This meeting is being recorded.
And Dr. Mohammed Assam has raised his hand. Can you please ask your question, Dr. Assam?
Assalamu alaikum. I am Dr. Asam. I am working as consultant pain physician in King Salman Medical City, Medina. My
Welcome,
question
Dr. Assam.
thank you very much, Dr. Huma. You have a wonderful presentation on both the very emerging and very questionable pain syndromes. My question is that what is the prevalence of fibromyalgia in your local population? Any local data available in Pakistan? And which criteria you followed in your clinic? And the second question is that is there any rapid screening tool for fibromyalgia patients? Thank you.
Thank you so much for your query, and thank you for appreciating the talk. Well, that the local data for Pakistan population is relatively scarce, but in our clinic, in our setup, we use the APT criteria for the diagnosis, and that is actually used as a very important screening tool as well, because there are only two simple questions which you need to ask the patient, and with these answers, you can actually deduce the diagnosis. You can actually guide your further cost-effective diagnostic tests, and then relieve the symptoms with patient inclusion in it. So apt criteria for diagnosis in our clinics and local data is still sparse on fibromyalgia and myofascial pains.
And what about the rapid screening tool? Sorry, what about the rapid screening tool for fibromyalgia patients?
We used the APT criteria, which was developed in 2019. The two questions which we asked about the multi-site pain being present and is it affecting the sleep or mood disturbances. If one or both of these are present, then we actually go on for specific testing. We elicit the history, the physical exam, and then the diagnostic tests. If there is no other systemic illness found, then we actually label the patient for fibromyalgia.
Thank you very much. And my last query is that this is for the trainees who are on the site. That is there any role of interventions like regional blocks in fibromyalgia?
Can I take the question?
Is there any role of interventional pains medication like regional blocks in the treatment of fibromyalgia?
Fibromyalgia is a widespread disease. It is not localized, as the disease is not localized to a particular part of the body. It can present in the head and neck, and then it can involve the arms or both the limbs, or it can go into the legs, the lower backs. As it is widespread, so there is a little role of regional techniques involved in the treatment of fibromyalgia. But yes, we can try other modalities inclusive of non-pharmacological treatments like cognitive behavioral therapy, but with interventions and regional blocks, I didn't find any data corroborating that evidence for the treatment of fibromyalgia. If some colleague wants to add, I would be very grateful.
Thank you. Dr. Hanan Akbar has raised his hand long before, so please go ahead, Dr. Hanan. And after that, we'll take the question from Dr. Shabir Jumani, who's our ex-president. He's present here, and he has also always been supportive of the PSA online lecture series. So he also have a small query. So first, Hanan, can you please go ahead, and then we'll close the talk with Dr. Shabir Jumani's comment and question.
Assalamu alaikum. My question is very short, Jel. As you mentioned in your lecture about the non-pharmacological techniques. So my question regarding your practice in Pakistan, that any patient coming to you and you think that the patient has fibromyalgia or myofascial syndrome. So what are you preferring if he has not taken already any non-pharmacological therapies? Are you referring them for the like cognitive behavioral and all thing, or you will start from the pharmacological treatments? What is the practice there?
Thank you, Dr. Hanan. So our localized practice is that we have on-ground psychological support as well. So our psych team is always there 24/7. We attend to consults within 24 hours. So we do start off with the non-pharmacological methods first, and we make the patient inclusive. And depending on what is the presenting symptom, we start with the pharmacological treatment alongside. But non-pharmacological treatments are offered and are being delivered to the patients on daily basis within consult period of 24 hours.
Thank you. Now over to Dr. Shabbir Jumani. Dr. Shabbir, are you there?
Yes, please. Can you hear me?
Yes, we can hear you.
Okay. Thank you very much, Dr. Asma, for making pain pathway very simple, presenting it very well. And thank you very much, Dr. Huma, for very well presented lecture. You really made fibromyalgia syndrome very simple, and I think everyone was understanding whatever you were saying, Now, my question is there any role of trazanidine or carbamazepine in fibromyalgia syndrome?
Yeah, thank you, Dr. Shabbir. Thank you for being there in the talk, and thank you for gracing the lecture with your presence. I'm really honored. And there are evidences of different receptors and serotonergic pathways being involved. So yes, anything which is acting centrally might be used, but I couldn't find literature data selecting a carbamazepine drug of choice for the treatment of fibromyalgia. If there is associated comorbid, like there is some mood elevation which is required, then in addition to the tricyclics, yes, carbamazepine was used as an adjunct, but not as a primary pharmacological therapy.
Well, I've tried trazanidine or carbamazepine, both in some of my patients with fibromyalgia and chronic pain syndrome, and I found it to be very effective, maybe in low dosage.
Yeah, I do agree that in our practice, what we found is that if the patients are presenting with chronic head and neck pains or chronic headaches, it proves to be of great benefit if it is used in adjunct with all the other therapies that we are trying to give to the patient.
I do agree.
Thank you.
Sir, would you like to conclude the session today?
Well, as I said, Dr. Smart was very well presented, lectured by both of you, particularly pain pathways. You made it very simple. Same thing with Huma, and I thank everyone who participated in the lecture. Today, I think the presence was 80 plus, which is a very, very good sign, I'm very happy. I'm really very happy that the thing which you started, Dr. Asma, a few years back, it's really now, I mean, it has become a tree, with all branches all over. Thank you very much.
Thank you so much for the kind comments, Dr. Shabbir. Indeed, it is, and I'm so grateful and so thankful to each and every participants who join us every alternate week on Monday, especially at nighttime. And even if we change the time according to the speaker's availability, they are there. So thank you, everyone. This success is owed by all of you who are here with us, and I really am grateful to each one of you who takes time out, especially for this academic activity, which we have tried to make at par. We try to ask the speakers to keep the presentations and the lectures precise, to the point, and updated. And I'm sure with your feedback, in every lecture, in every presentation, we try to make it, and we try to improve it with every feedback of yours. And believe me, your names, your email addresses, your phone numbers, they always remains confidential with us. We do send the feedback form to the feedback to the speakers, but the names are anonymous, and we hide the names, we hide the email addresses, we hide the phone numbers. So please be very open whenever you are giving the feedback, even if it is because it is necessary for the betterment of every lecture, every presentation, and every format. So definitely it will help us, and that's the main reason that we have come so far. So thank you very much. Kindly fill in the feedback form. Thank you, Dr. Huma, for presenting your talk on fibromyalgia. It was a very important topic, even though I wanted to present it on myofascial pain, but you were generous enough to get the talk from me, and thank you very much. Hope to see you all in the next upcoming week, not the next week, but the week next to that, with another lecture and another talk. Thank you, everyone, and have a good night.
Good night. Thank you very much.
Thank you so much, Dr. Asma.
Our pleasure.